It is great for the lung cancer world that cancer immunotherapy has changed the treatment landscape for lung cancer. But it's important not to forget all these first-line pivotal trials with immunotherapy, with or without chemotherapy. They were conducted with fit patients, so we define as PS0 and 1. And the median age of all the trials were 65 or less. But when you look at the real-world data, we know at least 40% or even more are unfit patients. And we define that as PS more than 2. Or elderly patients with a lot of comorbidities, some polypharmacies, or frailty, and they definitely not fit enough for our standard doublet chemotherapy. So when we look at the data, what we call the State of the Nation report just came out 4 weeks ago, the UK report. You look at these nearly 35,000 new cases of lung cancer. And the median age was 74 years old. And only about 54%, even though we only capture 83% of the population where we got accurate PS performance status, their staging and so on, 54% were PS0 and 1. And these are people we normally consider fit for systemic anti-chemotherapy. But we sort of look deeper into it, only 61% receive any form of systemic treatment. So we are saying 40% are undertreated. Now, for the remaining 46%, PS2 and 3, we assume, according to NICE guidelines, they don't get any treatment at all with immunotherapy. So immunotherapy was approved. The first one was with pembrolizumab for KEYNOTE-024. I think that was 2018. And then we got atezolizumab. Then obviously we got KEYNOTE-189, where you can combine chemotherapy, platinum doublet with immunotherapy. So we're looking at our latest data. And our latest data show for stage 4 disease, median survival is only 8 months. So we are not seeing this long-term survival. We are seeing with all these pivotal trials, they are talking about 30% 5-year survival. We are definitely nowhere near them. So there are this big group, real-world population, which are undertreated. So we designed this study called IPSOS. But prior to that, 2 decades ago, we designed a similar study called TOPICAL. So when tyrosine kinase inhibitor came along, EGFR inhibitor came along before the EGFR mutation discovery, they were considered the wonder drugs. So we did a similar study with anatinib, and those days we called BASS supportive care, and we randomized 720 patients from nearly 80 centers in UK. It took us about 3 years to recruit, starting from 2005. And we found, anatinib, then considered a wonder drugs, did not improve survival. There was a marginal progression-free survival benefit, but that is not clinically significant. And the median survival for both placebo, we use a placebo, all these patients allowed to have supportive care, and the median survival was less than 4 months. But however, when you get a rash, their survival shot up to 6 months. And also their 1-year survival shot up double as well, 10 to 20%, that kind of figure. And we sort of postulate that a not treated rash is due to some form of immune T cell recruitment to the tumor microenvironment. And that was our hypothesis. And when this immunotherapy came along nearly a decade ago now, we got excited. So we decided, let's try immunotherapy because it's non-cytotoxic. And hopefully all these frail patients, PS2 and 3, elderly patients who got too many comorbidities, can tolerate the treatment. So we designed a study called IPSOS. So we approached Roche and other pharma company, but Roche agreed to have a randomized phase 3 study. So we designed a study, we stratified, as you can see in our presentation in IPSOS. We do 2-to-1 randomization. And the reason we do 2-to-1 randomization, 2 for the atezo checkpoint inhibitor, and 1 for single-agent chemotherapy. By then, single-agent chemotherapy sort of been allowed for PS2 patients, but not for PS3, but we decided let's go ahead with it. So we randomized 2-to-1 randomization, checkpoint inhibitor, atezolizumab, with our chemotherapy, very gentle chemotherapy, oral vinorabine, IV vinorabine, or IV gemcitabine, which we all oncologists are very used to it. And we, after a long follow-up, 41 months, we met our primary endpoint, hazard ratio of 0.78. And we saw this 2-year survival benefit, 12% with chemo and 24% with atezolizumab. Now, people talk about, why are you not treating this patient with a platinum doublet? But they need to remember our results are, even with our chemotherapy, they are far better than first-line doublet chemotherapy for PS0 before the era of immunotherapy. So, and obviously far ahead of all this PS2 people have been trying for the last 20 years to improve the outcome. And there's a marginal benefit. And studies show the platinum doublet is no better than single-agent, more than single-agent chemotherapy. So I think this is a big finding. So now coming back to where we started, the real-world data, and we can say at least 40%, all these people don't get any form of treatment. Obviously, these are, I'm referring to this non-oncogenic cancer. We're not talking about EGFR and L or the non-small cell lung cancer. So it's a big population of unmet need. Neglected, elderly, and now randomized in clinical trials. So this is the first time after 20 years that we recruited what I call a real-world population. The median age was 75. 3 in 4 patients were over 70 years old, say elderly patients. And over 30%, well, 30% are over 80 years old. So that is, to me, that is, it's an important finding, after 20 years. And not only that, we look at the quality of life because they got they're symptomatic. We look at EORTC, the functioning scales, the symptom. And over 48 weeks of follow-up, we saw there was stabilization of all the functional scale. And hopefully, all this data will be available when it's published. And the symptoms improve as well compared to chemotherapy. And importantly, the dropout rate with gentle chemotherapy and atezolizumab, 13%. Very low for this frail population. And we're not talking about fit, young patients here. And when we look at sort of previous finding, there's a study called the Energy Study presented by the French group. And they use a Checkmate 226 protocol, approved in US as a first-line treatment, where the median survival was something like 17.6 months if you get ipi/nivo. And in the Energy Study, when you look at PS2 patient, the median survival was 2.6 months. So people need to remember, we are talking about different population. You're not careful, you can actually kill patient, as shown in the Energy Study. I think that's another study by the Swiss group, I think called SAAC, I can't remember, SAAK study, and they presented orally. And they look at patients with PD-L1 more than 25%, they treated with durvalumab. And they had to stop the study because of the toxicity issue. So we have to be careful when interpret all these first-line pivotal trials, which have been approved worldwide, FDA and UK as well, but they only restricted PS01 patient. We cannot extrapolate to the frail, elderly, unfit population who are not fit for standard platinum doublet chemotherapy. So that is the main message to take home. The first immunotherapy trial, comparing against a single-agent chemotherapy, which produced quite amazing median survival of 9.3 months, better than even of doublet chemotherapy, the old third generation, in platinum-eligible patients. Stabilization and improve quality of life measure, and no toxicity seen beyond what we see in PS0 and 1 patients. I think that's an important message to take from IPSOS study.